So I'm going to talk about MR staging prior to rectal cancer surgery and its relevance to improving results and outcomes for TME surgeons. Some of the data I'm going to present relate to the Mercury study, which was a prospective study evaluating patients with rectal cancer, all operated on by TME surgeons, and radiologists that took part in the study were all working to the same protocols and the same interpretation criteria. The impact of Mercury results and the question about whether it's generalisable relates to a number of key factors. Firstly, is consistent TME surgery taking place in a particular centre? Does that centre have standardised high-resolution MRI? Is there quality control for histopathology? And most importantly, is there an MDT discussion of the imaging and the surgical clinical findings, as well as input from the clinical nurse specialists and clinical individuals who've seen the patient to determine what's best in terms of the preoperative treatment strategy based on the stage of the patient as seen on the MRI examination. The importance of the standardised technique cannot be emphasised enough. It's very important that the patients are scanned with a high resolution technique, and you can see here we use 3mm slice thicknesses, a small field of view which is 16 to 18 centimetres, maximum 18 centimetres. We take quite a long time to acquire the images. These are taken with 4 to 6 signal acquisitions and a high resolution matrix 256 by 256, and it's a T2 weighted sequence using a long TR and TE, so that we get the in-plane resolution of less than a millimetre, and with this technique you can get down to a resolution of 0.6 by 0.6 millimetres, which enables us to be precise with regard to the depth of tumour spread and lymph node involvement, as well as other factors such as extramural venous invasion. So this has been published previously, and this was rolled out as part of the Mercury study to the 11 centres. What was also standardised was the way in which we report the MRI scans. So we have a pro forma which enables the radiologist to look for all the various prognostic features that are relevant in rectal cancer. So it's not just about the T and N stage, it's also about where the infiltrating border of the tumour is, what sort of advancing margin is being observed, how close the tumour is to the mesorectal margin, and also how much depth of spread the tumour has maximally, as well as other features such as venous invasion and the relationship to the peritoneal reflection, and also to point out areas that may be difficult during the surgical dissection. The histopathology assessment is also a similar matched pro forma, so that we can audit ourselves against the pathology gold standard, and that's very important for us to continue learning from pathologists. As you can see, the axial sectioning of the pathology specimen is a very valuable part of assessment of the tumour stage, and the relationship of the tumour to the mesorectal margin is absolutely key to determining what the outcome of the patient is going to be. And it so happens that these axial sections are almost identical to the axial sections that we see on the MRI, and it means that we can make some assessments ahead of the pathology in terms of the distance to the margin, the presence of tumour invasion into vessels, the presence of lymph nodes, and the depth of extramural spread. And we can, by matching the imaging and the pathology, we can start to learn from pathologists in terms of improving our image interpretation techniques. So what is the use of MRI for surgical planning? The importance really is in the identification of the clinically unsuspected potential involved mesorectal margin. That can not always be identified on clinical examination. Of course, fixity is a very good example of this, where a tumour may appear fixed not because it's very locally advanced, but mainly perhaps because the prostate is enlarged or the tumour is very bulky intraluminally. And equally, a mobile tumour can also have sites of disease that extend to the mesorectal margin that may not be accessible clinically. So we also look for patients that have good risk features so that they're not overtreated. And we have seen from our experience with the Mercury study that a lot of the early T3 tumours, regardless of whether they have nodal involvement, provided that the potential mesorectal margins are clear, they do as well as the earlier stage tumours, and therefore they needn't undergo routine preoperative therapy. A particular role of MRI is for planning low rectal cancer patients, because the key information regarding the radial margins are best assessed using the MRI, because you can relate the relationship of the tumour to the intersphincteric plane and determine whether the mesorectal plane is safe for surgery or whether the extralevator plane is necessary. And so the combination of these pieces of information enable us to determine the poorest tumours that require quite intensive preoperative treatment, as well as the more early stage tumours that can be operated on primarily without any preoperative treatment. We can also look at the response to treatment after the patients have received chemoradiotherapy to determine how best to ensure a good outcome. So the technique uses a phased array coil, which is a surface coil over the pelvis. It enables the scans to be acquired using a small field of view, and it also improves the signal to noise that we previously struggled with. So the radiofrequency coil and the improvements in technology of those devices have increased the ability to get good quality, high resolution images, and using a very small field of view, it gives us the in-plane resolution that we need to assess the tumour, the mesorectum, and indeed disease outside the mesorectum. So the previously used techniques of endorectal coils are rather difficult because they are operator dependent, and the main problem with using endorectal techniques is that you start to distort the tumour, and in fact you push the tumour against the radial planes and actually make those areas more difficult to assess on imaging. So the fundamental aspect of staging these patients is that they need to be fully informed of the length of the scans, to be comfortable and pain-free, and we do use intramuscular buscopan to improve the quality of the images by eliminating some of the bowel spasm and bowel motion. One of the important aspects of staging low rectal cancers, and indeed all rectal cancers, is the position of that surface coil in relation to the rectum. It's very important that the lower edge of the coil is at least 10 centimetres below the symphysis pubis, otherwise you end up with very poor quality images for the low rectum. This is an example of a patient who's been scanned with the coil placed too high, and as you can see on this image, the signal to noise is not good enough in the low rectum, so that when you then correct that, you can see the improvement, and you, as surgeons, you can tell if the scan is being done correctly, because you should see the symphysis pubis in the centre of the image. If it's at the edge of the image, you know that the high resolution images will not be of good quality. So these are the differences between a patient that's been done with the coil placed too high. You can see the symphysis pubis is at the bottom of the image. The consequence of that is that there's not enough signal to noise from the anal canal, whereas here the symphysis pubis is in the centre of the image and we've got good image quality for the sphincter. And you can see that on the axial images. Here you can barely make out the puborectalis sling. You can't really see the structure of the distal anal canal and rectal wall, and here this is where it's been placed correctly. You can see the puborectalis sling and the rectal wall quite well. So these are the advantages of just a little bit of attention to detail when performing MRI of the rectum. The key points about the technique is that all the imaging is T2 weighted. There's no need for giving intravenous contrast enhancement. The T1 weighted scans are not helpful for staging colorectal disease because it doesn't demonstrate the layers of the rectum adequately, and there is a tendency to overstage using the T1 weighted scans. Here's an example of such a case where There's very low signal on the T1 weighted scans, which in fact was due to edema, and so the patient would have been very badly overstaged if the T1 weighted images were the main way of interpreting the scan. But in fact on the T2 weighted scans it's very clear that there is no disease in the posterior mesorectum. So here's an example of a scan where the contrast has been used, and you can see that it really you've lost all the useful information, because in order for contrast enhanced scans to be interpreted, we have to saturate the fat. In doing so, we lose a lot of the anatomy, and in the end you really have a very poor quality image for interpretation. So the protocol is, in summary, sagittal T2 weighted scans with a large field of view axial image, and then we go straight to the high resolution scans through the tumour, and also we do some coronal imaging perpendicular to the anal canal so that we can see the intersphincteric plane. So this is the example of the sagittal scan and the parameters that we use for the sagittal scan, the large field of view axial imaging, and the high resolution T2 weighted scans, which are done perpendicular to the long axis of the rectal wall. And it's very important that this is done in this way so that you don't overestimate the disease. You can imagine if you're going through the tumour at an angle, you can artificially extend the depth of the tumour and end up overstaging the disease. So this is very critical. And when we do this, we can see the layers of the rectal wall, we can see the mucosa, the submucosa, the circular and longitudinal muscle coats, which enable us to give some idea about the depth of penetration of tumour through and beyond the rectal wall. These are some cadaveric and MRI imaging, just to show what we can see on the imaging in terms of the pelvic anatomy. So we can see the mesorectal fascia and the presacral fascia. These are the two structures that are almost in the midline, they're almost superimposed on each other, and this is the potential plane for the TME dissection. And here we have an example of the rectosacral ligament or fascia, which we can see also on the MRI as a structure which is low signal intensity, extending from the back of the rectum to the front of the sacrum. Here we have an example of the peritoneal reflection, which we see over the surface of the bladder extending towards the anterior wall of the rectum, and we see here on the cadaver as well. And this is important because we must understand as radiologists that the peritonealized surface of the rectum isn't going to be a surgical margin. Nonetheless, it's important to know that the tumour is close to the peritoneum so that the surgeon doesn't inadvertently cause tumour spillage during mobilisation of upper third and rectosigmoid tumours. So here's an example of the peritoneal reflection on the axial image, and you can see here there's a tumour that's sitting right on the peritonealized surface. And on MRI, it's sometimes difficult for us to say for sure that the tumour has gone through the peritonealized surface, but what we can do is warn the surgeon that this may be occurring. But it's important to note that the tumour is actually ulcerating through the peritoneum here, but it is not a positive circumferential resection margin. It's a T4 tumour, which are different things. In male patients, we can see Denonvillier's fascia quite well on the MRI. This is a histopathology section showing it, and the cadaver MRI showing fluid that's got between the prostatic capsule and Denonvillier's fascia, which is on the anterior aspect of the mesorectum, and it's a horizontal band, horizontal structure, which we can see on the MRI scans. You can see it on the back of the prostate here on the sagittal MRI, and it's distinguished from the mesorectal fascia because you suddenly see low signal intensity or dark thickening of the fascia at that point, which is due to the overlying Denonvillier's fascia. And here we can see this effect on an axial image. You can see the mesorectum's quite thin here, and then suddenly it becomes darker and thicker because of Denonvillier's fascia. And this is the corresponding histopathology section, and when we zoom up we can see that it's actually a different structure to the mesorectal fascia. It contains small muscle fibres because of its embryological origins from the pelvic floor. So another aspect of TME surgery is the nerve preservation that goes on, and the cadaveric section here shows exactly how big some of these nerve trunks that are coming forward in the pelvis are. And here we can see the formation of the hypogastric nerve, which lies in front of the sacrum but lateral to the mesorectum, and comes forward to then give branches which then supply the pelvic floor and pelvic organs. And we can see that on the MRI. We can see, as we've cut a hole through the rectum and the mesorectum, we see the pelvic sidewall nerves here, and on the MRI, if we go into the same plane, we see it as a complex meshwork of high signal intensity structures which form this plexus going forward to supply the urogenital organs. And on the coronal oblique image, this is the sacrum at the back, you can see the nerves just lateral to the fascia coming forward towards the neurovascular bundle on both sides. And these structures are quite easy to distinguish from the vessels because they don't contain any signal void, because there's no flowing blood in the nerves. So clearly these will have a different characteristic to the vessels, which will have some black within them because of this signal void of vessel flow. The mesorectal fascia can be seen on an MRI, as well as on here we've got them on the histology and cadaver sections here. These are all from the same cadaver, and the important thing to note here is how different the mesorectum is in texture compared with the pelvic fat. And you can see within the mesorectum and on the histology section too how much vasculature there is within the mesorectum, how much connective tissue and mini sort of septa within the mesorectum itself, and how complex a structure it is compared with the pelvic fat, which is rather featureless and really doesn't have very much going on in it. So there's a very clear distinction on imaging and on pathology between pelvic fat and mesorectal fat. And here we can see it rather well on an in vivo image, where we can see the tumour, the rectal wall, but the mesorectum seen very nicely with all the lymphovascular structures within it, as well as the connective tissue that marks it out as different to pelvic fat, and the fascia outlining the mesorectal compartment. The MRI also provides us with an opportunity to see some of the normal variants of anatomy. So, for example, here we have a persistent middle rectal artery and vein that has perforated through the mesorectum and will go to branch towards the pelvic sidewall vessels. So this is a route for the development of pelvic sidewall nodal disease, as we see in certain individuals, but is also a reason why the avascular plane of TME surgery isn't always avascular, and this is an example of such a normal variant. So as radiologists, it's important for us to point this out ahead of time, because it may help the surgeon avoid some unnecessary bleeding during the TME dissection. So for us to be able to understand pelvic surgery, it's nice to think of the pelvis as distinct compartments. You're dealing in rectal cancer surgery with the mesorectal compartment, but on occasion the disease can spread beyond the mesorectal compartment, and understanding that disease has gone through that compartment into an adjacent area will enable preoperatively to define, for example, a different sort of dissection. So, for example, if the tumour has gone through the presacral fascia posteriorly towards the sacrum, you would not want to do a TME operation. You actually may want to do a posterior exenteration. Similarly, if tumour has gone through into the lateral compartment, you may want to do a different type of dissection. And therefore, the MRI is a very helpful way of planning the surgical approach. T-staging by both endoluminal ultrasound and MRI have been shown to be reasonably equivalent. The main limitation for the endoluminal ultrasound techniques, however, is that the depth of penetration for the very high frequency probes is quite limited, which does prevent the true assessment of the depth of extramural spread of tumour. So whilst on the face of it the detection of T3 tumours by both MR and EUS is equivalent, the ability to substage those T3 tumours by EUS is somewhat limited. The other obvious disadvantage of EUS is clearly that it cannot really truly assess the relationship of tumour to the mesorectal margins because of the limited field of view from the endoluminal scope. The other problem is that for patients with very flat lesions, the endoluminal ultrasound at high frequency is extremely useful in identifying those sort of patients that are suitable for local excision. However, it does fall down when we start to assess the rather bulkier polyps, also suitable for local excision, and some of these can be very difficult to assess using endoluminal ultrasound techniques. So MRI can complement the use of EUS, particularly for patients with larger, less flat lesions, and therefore be able to identify exactly where the base of the stalk for a polyp is, and to determine whether such patients may be suitable for an attempt at local excision. The other main advantage of MRI is in the identification of disease that may be clinically unsuspected and disease remote from the luminal aspect of the tumour. And here we have an example of a patient who has a pelvic sidewall lymph node which is outside the mesorectal margin and would not be accessible clinically. MRI of low rectal cancers is a particular advantage because you can relate the tumour to the intersphincteric plane and to the levator muscle, and so can make an assessment, as in this case where the tumour is anteriorly placed but there's a good margin of mesorectum anterior to the advancing edge of the tumour, which means this patient would be amenable to a low anterior resection, which is what happened. And it means then that patients with low tumours don't all get an abdominoperineal excision, because a lot of them may be easily resected by the TME plane. So in evaluating the impact of MRI, we carried out an audit of the assessment of patients within the MDT setting. And in 2003 and 2004, we looked at the margin positivity rates in patients who were discussed by the MDT and those that weren't. And we found that patients who had escaped that process, where they didn't have an MRI or didn't have a discussion of the MRI before surgery, had a very high positive margin rate. 26% of those patients were margin positive that were not discussed in the MDT setting. When we mandated MRI and MDT discussion of all new rectal cancer patients and re-audited our practice, we found that the margin positivity rate went down to 3%. And so that highlighted to us the importance of having a process where such patients are identified preoperatively rather than discovering them at surgery. The advantage of a preoperative strategy is that patients with potentially involved margins can receive preoperative chemoradiotherapy so that they then get downstage, so that the tumour regresses away from the mesorectal margins. And here's an example of a patient who received chemoradiotherapy as part of the EXPERT trial, where after chemo you can see that there was tumour regression, which there was further regression after completion of the radiotherapy. And you see here in the final specimen that there is fibrosis which had extended to the margins where tumour had been, but in fact the margins were free of disease. And similarly, this can also apply to upper third tumours where there is extensive margin involvement, and giving preoperative chemoradiotherapy does, by eliminating that positive margin, does improve outcomes for these patients. And an example of this is shown here, where we have a tumour that had extended to the mesorectal margin in an upper third rectal tumour. After chemoradiotherapy, this was all downstage, so that all we could see at the edge was fibrosis, and so this patient successfully was resected with a clear circumferential resection margin. So even tumours of the distal sigmoid, rectosigmoid and upper rectum can be staged using MRI, and we can identify even high-risk patients that maybe perhaps some centres wouldn't treat, who would be amenable to preoperative chemoradiotherapy with the resultant clear margin. So with discussion of MRI, we can start to think about eliminating most instances of CRM positivity and as a consequence start to eliminate local pelvic recurrence by a combination of identifying patients that are suitable for TME surgery alone and those patients that need preoperative chemoradiotherapy to enable tumour regression away from the mesorectal margins. So the other aspect is looking at the depth of spread of tumours, because as we've highlighted in the past, some of the T3 tumours don't have a particularly high risk of developing pelvic recurrence, and identification of those patients is particularly important. In order to do that, we need to be able to see that our measurements of depth of extramural spread are equivalent to that of the pathologist. And in the Mercury study, we showed that our measurements of depth of spread were indeed equivalent to that of the pathologist. And this is an example. This is a tumour that on MRI was considered to be either a T2 or an early T3, but had no adverse features. In fact, on the pathology, it turned out to be a T3, but the importance is that we have identified this as an early stage tumour with no adverse features, which is exactly what was shown on the final pathology. It means that we can start to identify these early stage T3 tumours that, regardless of whether or not they have nodal involvement, appear to do well in terms of 5-year follow-up, with 85 to 90% 5-year cancer-specific survival. So it means that these patients do not require routine preoperative treatment because the survival benefit will not be observed. And we have demonstrated this in the Mercury study. This is a piece of work that is in press with the Annals of Surgery. And what we had shown is that these patients with early stage tumours, clear margin, and no adverse features such as extramural venous invasion on MRI could undergo primary surgery and with negligible risk of pelvic recurrence at long-term follow-up. This contrasts with the poor risk patients who are at risk of systemic failure, and such patients in our network would be offered preoperative chemoradiotherapy, and in the past we've treated them with chemotherapy and chemoradiotherapy in the EXPERT trial and EXPERT C trial, and the NCRI are also planning treatment and studies that will involve the use of systemic chemotherapy because of the risk of distant failure rather than pelvic recurrence for these high-risk patients. And here we can see the effect on the survival curve. This is the Erlangen registry data, but what it shows is that tumours with more than 5 millimetres spread have only a 54% or 5-year cancer-specific survival. And part of the reason for this is that a lot of these patients have extramural venous invasion. In pathology specimens, it's seen in 30 to 40% of specimens resected. It's known to be associated with synchronous metastatic disease, and we've now shown that MR detection of this is an independent prognostic factor for poor survival. This is an example of a patient with spread into a vessel, and you can see it's characterised by tumour extension into the vein and serpiginous extensions through and beyond the rectal wall following the course of a vessel, and that's for us indicative of venous invasion, but it's also a marker for systemic failure because despite the clear margins, this patient developed irresectable liver metastases after 1 year. So in future we hope to treat these patients rather more aggressively and intensively with preoperative systemic therapy. And this is the pathology evaluation of patients with histological venous invasion, and you can see there's a distinct survival disadvantage with only 30% surviving with disease-free survival at 3 years. And the MRI is similar in that with patients with large or medium vessel invasion seen on MRI, there is a 3-year disease-free survival of only just under 30%. So this is the structure of future trials, and this is for MRI identified EMVI positive patients. These patients are going to be offered chemotherapy or chemotherapy with short course radiotherapy in the Copernicus trial in an attempt to address their risk of systemic failure. So assessing the CRM is an important part of preoperative staging, and the distance to the fascia is defined as 1 millimetre as the cutoff for whether the margins are going to be clear or involved. And we use the MRI assessment of the extent of the most outer aspect of tumour spread to the mesorectal fascia to make that decision. And when we used these criteria, we showed that the specificity prediction of a clear margin was very good. It was 92%, and it could accurately predict whether the surgical margins would be clear or affected by tumour. Not only that, in the Mercury study we showed that it could be reproduced in the various centres taking part in the trial. And when we compared positive margin rates and local recurrence for the particular distances, we found that increasing that distance to 1 millimetre, beyond 1 millimetre to 2 millimetres or 2 to 5 millimetres, did not increase the rate of accurate detection of margin involvement. So as far as lymph nodes staging goes, we are looking to identify patients with nodal metastases, but really we are limited in that we're not really be able to see microscopic nodal invasion or even part replacement of the lymph node. Really we're limited to being able to see fully replaced or lymph nodes that have been so replaced that the tumour has breached through the capsule of the lymph node. And the high-resolution MR enables us to see some of these lymph nodes, and when we see this feature, it has an accuracy of 85%, a sensitivity of 83%, and a specificity of 86%. And this is on the basis of being able to identify nodes that have had tumour breaching the capsule of the lymph node, giving the irregular borders, or partly replacing the lymph node, giving the mixed signal intensity, as we can see here. And this is a histological example where the lymph node has been partially replaced by tumour. There's extracapsular extension of the tumour, giving this irregular border, and the mixed signal intensity due to the tumour being different to the lymph node surrounding it. And here's another example of a mixed signal intensity lymph node. You can see the inhomogeneity of the nodal architecture, giving rise to its malignant characteristics. And here we can see on the histology section mixed lymph node and tumour cells within. Benign lymph nodes are characterised by very smooth borders and uniform signal intensity, and this enables us to be fairly certain when we see these features that they're unlikely to be malignant. The main limitation for MRI really comes from not doing the scans properly. So here's an example of a patient where the field of view has been increased to 22 centimetres, which on the face of it doesn't seem like a serious problem. And you can see here the lymph node looks fairly smooth bordered, and importantly it's quite homogeneous, and so this would be regarded as a benign lymph node on this particular MRI. Now this patient was scanned again within a few minutes using a smaller field of view, and you can see how the lymph node looks completely different. We now can see that the capsule has been infiltrated by the tumour, and that the capsule itself is irregular, and there's mixed signal intensity. So we would be quite confident here in calling this a malignant lymph node. So the only difference between these two scans is the field of view, and what this has affected is the in-plane resolution. The in-plane resolution on this scan is much higher, and it enables us to see subtle changes to the lymph nodes that enable us to identify the malignant nodes. So pelvic sidewall lymph nodes are an interesting phenomenon in rectal cancer. We see it in a proportion of patients, and as in this case, there's mucinous deposits occurring in the pelvic sidewall compartment. We investigated the importance or significance of pelvic sidewall lymph nodes in the Mercury study. Firstly, we noted that the prevalence of pelvic sidewall lymph nodes was 11.6%. We saw it in 38 of our 326 patients where we had staged the pelvic sidewall nodes. What was interesting is that the majority of these lymph nodes were following the external iliac drainage systems, with very few seen more cranially. And what we showed was that the survival for patients with pelvic sidewall negative disease versus pelvic sidewall positive disease was significantly different, so that patients who were sidewall negative did have a better disease-free survival. The other main difference that we saw between the pelvic sidewall positive group and those with negative disease was that in the pelvic sidewall positive group there was an increase in T stage, that more of these patients with sidewall positive disease had involved mesorectal lymph nodes, and very importantly, a greater proportion of these patients received preoperative neoadjuvant therapy. So this means that when we match these patients for both the pathological radiological T stage, their mesorectal end stage, CRM status, as well as EMVI, we found that the difference in survival was not significant. What this tells us is that the pelvic sidewall positive patients are in themselves a group of patients with more advanced disease than the pelvic sidewall negative patients, and that when you account for the likelihood that these patients are more likely to receive preoperative chemoradiotherapy, there seems to be no disadvantage for having pelvic sidewall positive disease if matched stage for stage. There's an intriguing question of whether patients who have nodes close to the fascia should be routinely treated with preoperative radiotherapy. How often are nodes involving the fascia a cause of a positive margin? Well, this is an example of a nodule of tumour that's sitting right on the fascia, which is unmistakably tumour and disease, and we would regard that as an involved margin, and indeed it was on the pathology. However, other lymph nodes, such as this, which sit close to but not infiltrating the fascia, very rarely cause a positive margin, and we've seen that from auditing the Mercury study patients. And what we have found was that there were very few cases of a positive margin due to a lymph node alone. In fact, only 4 cases were due to nodal involvement out of the whole of the 396 patients evaluated. So it means it's an unusual cause of a positive margin, and we therefore would recommend caution when suggesting neoadjuvant therapy based solely on the suspicious lymph node close to the fascia. So in summary, the MRI can be used to start to stratify patients on the basis of both local risk of failure as well as distant failure, and we have developed, along with many other centres in the UK, particular criteria for determining which patient should receive preoperative treatment. Currently, this is our practice, so patients with tumour within 1 millimetre of the mesorectal fascia would receive preoperative treatment. T3 tumours that are infiltrating the mesorectal margin below the level of the levators and encroaching on the intersphincteric plane would also be considered for preoperative treatment. T3C or T3D tumours at any level, because of their risk of distant failure, receive preoperative treatment, as well as T4 tumours and N2 tumours, as well as patients with extramural venous invasion. In reality, a great majority of patients will have at least 2 or 3 of these features visible on the MRI, so the decision to give preoperative treatment is usually based on the patient having the full-blown poor prognostic phenotype. So in summary, MRI is giving the surgical teams an opportunity to start to stratify patients according to risk that they see in terms of pelvic failure or distant failure. It means that despite the fact that 80% of primary rectal cancers are T3, we do not need to give routine radiotherapy to 80% of our patients. The figure is much lower than that, but what we do need to think about is intensifying treatment for the high-risk patients and allowing those patients who are unlikely to benefit from preoperative treatment because they have good prognostic features and a safe margin, the ability to benefit from a primary surgical approach with the lower morbidity that will ensue from avoidance of radiotherapy in those particular cases.